Welcome to the Dusty Muffins, where menopause meets sisterhood and strength. We're three menopause specialists coming together to laugh, share, and empower you through the wild ride of menopause and perimenopause. Whether you're curious, confused, or just looking for real talk, you're in the right place. We're here to answer your burning questions, educate, and advocate, all with a dash of humor and a lot of heart. So pull up your chair and join the conversation. Before we dive in, please remember, while we're doctors, we're not your doctors. This podcast is for educational purposes only and is not a substitute for medical advice. We encourage you to partner with your own medical clinician to address your unique health needs. This is the Dusty Muffins.
I'm Dr. Rebbecca Hertel. I'm a board-certified osteopathic family medicine physician and a Menopause Society certified practitioner. I have a private telemedicine practice, and I see patients in several different states.
I am Dr. Aoife O'Sullivan, a board-certified family physician and Menopause Society certified practitioner, and I see patients through my telemedicine practice here in Oregon and Washington.
I'm Dr. Hart Kress, a board-certified women's health nurse practitioner and menopause certified practitioner, and I see patients via telemedicine in several states as well.
I'm going to bring these ladies up, and then I'm going to let them run with it, okay? All right, Dr. Rebbecca Hertel, ladies and gentlemen. Dr. Aoife O'Sullivan and Hart Kress. I love these ladies. We've met along the path, and here we are, 6 months later, on the stage together. Enjoy.
Thank you. Thanks, everyone. And let's give it up for Dr. Gila. Are you guys having a good time? Yes, it's awesome. Thanks for having us here. So I'm Dr. Rebbecca Hertel.
I'm Dr. Hart Kress. I'm the DMP of the two docs in the DMP.
I'm Dr. Aoife O'Sullivan from Portland, Oregon.
And we're the Dusty Muffins. Good to meet all of you guys. So Christine's going to get us
Yeah, so we had fantastic responses. Thank you so much for your questions. There were lots of questions. We're not going to get to all of them, but we thought we'd at least try to get through some of the questions that you all sent us, and then we'll get to also you share with our listeners as well. So by a show of hands, have any of you been told that you cannot use both vaginal estrogen with your patch or your gel? Does anybody have that experience? Yeah, a couple. Awesome. I'm military, so I was in the middle of the pharmacy with all the 80-year-olds on a Tuesday afternoon, and I went up to my pharmacist to pick up my vaginal estrogen and to pick up my gel, and I got told to go sit back down. I'm like, what's the problem here? And so then I got brought over to the secret room, and they said, in front of everybody, and they're like, you cannot be on vaginal estrogen with systemic hormone therapy. And I said, why? And she's like, it's way too much. I'm like, too much what? I'm like, too much of a good time because I need all of it, right? I'm like, I don't understand. She's like, your estrogen levels are going to be through the roof and you're going to have breast cancer and you're going to die. And so I turned around to all the men in the waiting room, and I said, let's talk about it. And so I said, you are really clueless. And I was kind of mean because I was kind of embarrassed because like a lot of people heard the conversation. And so you can use both vaginal estrogen, which every vagina in the entire world forever needs. Your mothers, your grandmothers, the boomers who are pissed and missed out on hormone therapy, get them on it. It's the nursing home prevention plan. So many women, it's the second largest receptor site for estrogen. Everything from your pubic bone to your tailbone is screaming when your ovaries go into retirement. And so, women will come in with UTIs or urinary urgency. They know where all the bathrooms are in Target in every state, right? Or they come in and they're like, I have I'm itching. And it's always estrogen, and it's not going to increase your levels. If we drew your blood, it would be the same. You can use them all the time.
And I say if I was on a deserted island, it would be my vaginal estrogen, my Retin-A, and my sunscreen. So can't leave home without it.
The next question was actually related to that one. It was, do you have to use progesterone with your vaginal estrogen? The short answer to that is no. And the reason is because it's such a tiny dose. The vaginal tissues and the vulval tissues need so little estrogen to stay healthy. And if you were to use it for a year as we prescribe it, and you added up all the estrogen in that cream or whatever you're using, the suppository or pill, comes to about 1 to 2 birth control pills worth of estrogen over the space of a year. So really, really safe, and you do not need to use progesterone with it.
Yeah, it's a really good point, because I think sometimes they get nervous about just, you hear estrogen, and then they're like, I need progesterone too. And so that just stays local, which goes back to the other question of, can you use your local vaginal estrogen with your systemic? And that's just because some women with their patch, their gel or spray, it doesn't go to the vaginal tissue. So you actually do need both. So anything else on that?
No.
Christine? All right.
Yeah.
So by a show of hands, how many of you were talked to about puberty and when you were going to start puberty? How many of you were talked to about that before when you were younger? Like what your periods were going to be like, or that you were going to start your period? What about pregnancy? Did they talk to you at all about what to expect when you were going to be pregnant at all? So how many of you were talked to about what to expect in perimenopause or menopause? Right. But did you even know what perimenopause was? I mean, that we were not taught that. And so the question is what do you want women to know in their 30s and 40s about menopause? And this could be a whole entire hour-long conversation with everyone, but we all three of us picked one. And so mine was women in their mid to late 30s can start having symptoms. So, your clinician should be starting to talk to you in your well woman visits or your physicals in your 30s. Hey, are you starting to have period changes a little early, a little later? Is your mood changing? Those are all types of things, and then starting to have that conversation. And what about you girls?
Yeah, so I think tracking symptoms is super important. In clinic, I love the green climacteric scale, and providers love data. So when you go in with more than I feel, because, nobody should take away your feelings, but sometimes you get gaslit when you say, I feel that this is hormone related, but when you bring them in data. So it's a 31 question symptom, and you rate it from 0, I'm not having, to 3, I want to light myself on fire, and you add up the score, and if it's more than 15, it means you're deficient in hormones. And so it's a good tool to bring your providers. And then on the Louise Newsom from the UK, she has lots of wonderful information on the Balance app. It's free. And you can also track symptoms on the Balance app. And the great thing is if you go back 6 months later, you can print off what you did before and you can show your progress. And so what I do in clinic is when I see a patient for the first time, I do the score, because if your score is a 31, it's validating. You feel like crap, but it's validating to see a number that concurs. Yes, you do feel like crap, and this is not in your head, and this is really a real deal. And then when you come back in 6 or 9 months and you're 5, right? And it's like, yes, I was right. I needed these hormones, and look at me now.
Mm-hmm. Yeah. And then I think it's really important to leave here knowing what the FDA approved indications are for hormones, because if you have done your own research, you pretty much are sure what's going on with your body. But then you get into your doctor's office, and some doctors are very conservative. They might even know a little bit about menopause and hormone treatment, but it might be quite limited. And they are often very stuck on the FDA-approved indications. And so many years ago, when they first started developing our hormone therapy, they applied to the FDA for certain indications. So they were vasomotor symptoms, which are your hot flashes and your night sweats, genitourinary syndrome of menopause, which is your vaginal dryness and irritation, especially recurrent UTIs as well, and then prevention of osteoporosis. So if you are dealing with a doctor who is very strict about those FDA indications, I feel like these are good tools in your tool belt, because who is not at risk of osteoporosis? We all know that as soon as we hit menopause, our bone density starts to drop. And so that covers every single woman, really. And I don't know too many women in their 40s who do not have some vaginal dryness. So if you ask the right questions, if you have the right doctor, they will get to an FDA-approved indication, but I think it's good for you to know before you go into your appointment.
Yep, that's awesome. So the next question that we got was, do you have to use progesterone if you've had a hysterectomy? No, you don't need it, right? Because estrogen thickens the lining of the uterus. If you don't have a uterus, nothing's going to get thickened, and progesterone or progestogen will thin out the lining of the uterus, keeps it a nice even balance so that you don't get endometrial cancer. That's what we're protecting you against. But you have receptor sites for progesterone, just like estrogen and testosterone. So yes, you can have it. I have so many patients that come in and say, all I would like is a little sleep. Could I please have progesterone? And it's like all the providers are withholding it because they're like, the only good is it to protect your uterus. No, that's not true. It's good for sleep. It's good for mood. It's good for, I even think it's good for helping with some of the joint pain because it's relaxation. And everybody deserves good sleep because let's be real. The number one thing that makes us menorrhagy is not sleeping. And if we had a drone out around our hotel last night, I am sure there are some of us that were up between 2 and 4, the bewitching hour. I wish that bewitching hour could just be moved just a little bit, right? Just slide that a little bit. And I always say, if we all would just get together and just start texting, I respond to a lot of people on Instagram between those hours because I'm up, so why not? I mean, we could solve everything, right? Like we could solve the world.
And actually, they say that when doctors are having a conference about menopause, the first symptoms that are always mentioned are the vasomotor symptoms, the hot flashes and night sweats. But what we find in practice is that is not what women complain of when they first come to see us. They're usually talking about new anxiety or worsening anxiety, same with depression, not able to get to sleep, brain fog, memory problems, concentration, focus. Any woman with ADHD hasn't been diagnosed has been holding her life together with Post-it notes and a box for her keys, and that all falls apart during perimenopause, and all hormone related as well.
And I just want to add, if you talk to any of us, what got us into this space is our own symptoms and not knowing what the heck was wrong with ourselves, and then trying to find somebody to help us. And so, we all have a story to tell. We get into this space because we were gaslit too. And so, I think it's just important to know that I think it's really cool is that I'm living the experience right along with my patients. And the one thing that I have learned is no symptom is off the table. Like if you had asked me 30 years ago, and I was a menopause practitioner when I was young, I was bad. And if someone told me burning tongue, I would have called one of the logo, I don't get it, right? Yeah. Or itchy ears. I couldn't wear my hearing aids. Everyone's like, my husband's like, you're so loud. I'm like, I know, I'm from New York. And he's like, if you'd wear your hearing aids, I'm like, it makes my ears itch. No idea that was a symptom. Yeah.
And knowing all these symptoms makes doctors' lives easier. It's so much harder when you have your patients coming in because we've estrogen receptors all over our body. When we lose our estrogen, it affects every single part of us. And so then you go into your doctor with dry eye, itchy, an itchy spot on the back of your leg.
Itchy muffin?
Itchy muffin.
An itchy muffin.
Not just dry.
A dusty muffin. A dry, dusty muffin. And your doctor is like, I don't know what the hell is going on here.
And we are not men, so we don't walk around adjusting and moving things around. So it's frowned upon. I tell my boys that all the time. I'm like, we don't go around doing all of these things. So can you please stop adjusting in front of my face?
I know. But I mean, that dried out dusty muffin, I mean, that's like a real deal. Like one of the things I couldn't figure out, again, clueless provider, been doing this for a really long time, is, you're hot and you're getting going. I have to yell sex night and my dogs get off the bed, right? And I'm like, I'm all in the mood. And then like I have a ceiling fan and I've learned I cannot have sex with a ceiling fan because as soon as I open my legs, my vagina is like dry as dry can be. The air, it just sucks all the life out of it. And then women our age had not learned what lube is, right? Like I cannot, if anybody
it was frowned
knows,
upon, right? It was like, you need lube. If you need lube, then I'm not doing something right, or you're not excited or whatever. And I'm like, what?
Right, but what I can't figure out, so if anybody knows this, I really would like to know, and we could do it on the podcast, we're outside filming today, is how you eloquently make the transition to get that lube on him and you. I cannot figure it out. It is, but so
There's no elegant
There has to
no.
be. Because I asked my 27-year-old, I said, so my son's horrified most days about me. And so I said to him, I go, do you use lube? Because, he's newly married. I want to make sure she's good. I gave him a whole box of vibrators and vaginal and all kinds of things.
These are great wedding
It's great
gifts,
gifts.
bridal party
Yeah,
gifts.
that was Christmas. Imagine opening that stocking. And my son said to me, he goes, duh. And I said, what do you mean, duh? He's like, I've been using lube since I've been having sex. And I said, oh, you mean the year before you got married? And he's like, yeah, the year before I got married. They learned it in sex ed. I did not. I learned don't do it. And I was like, yeah, maybe, no. And then I learned don't get pregnant. That one I did all right there.
Yeah.
So anybody knows the secret of lube, I would really like to know.
Use a lot, and it doesn't matter if you have to be, incognito grabbing it or just the hold on a second, let me grab what I need to grab.
Gotta figure it out.
Just put it everywhere.
Yeah.
The next one is, do you have to use bioidentical hormones? I think we talked about bioidentical a bit today, but just to go over it again, it's a marketing term, really. Bioidentical just means that the medication you're taking is identical under the microscope to the hormones that your ovaries are producing every day. And so even the FDA-approved medications that we use, the patch, the gel, the spray, the oral estradiol, that's all bioidentical. It's all identical to your own hormones. Your body doesn't react in a bad way to it. Like it would to some of the other medications, which are more synthetic. And the same with the micronized progesterone. So you don't have to go to a compounding pharmacy and have things made up specially. You can get them at your regular pharmacy, all covered by your insurance. A lot cheaper.
Yeah, inexpensive, absolutely. And not that, sometimes people do need them compounded depending on if they can't tolerate them. But we always start with the FDA-approved bioidentical, and because they're inexpensive, and there are a lot of options as well. So.
And, sometimes women don't tolerate progesterone, right? Or you have a peanut allergy, or you don't have the funds to do compounded. And so sometimes you have to use the synthetic progestogens. It is not the end of the world. It is not. And, what's important is that is that you can use something that your body is going to allow you to use without having side effects. And that is something that fits into your lifestyle. So sometimes we have to use those synthetic progestins, and it's okay. I think
It's all in our toolbox.
Exactly.
We've got this nice big toolbox, which is so important that, if something doesn't work, then we go down the line, and we can go down the line and go down the line. And so, the first thing is, yes, you can have hormones, we have that conversation. And then, okay, now here are all the things in our toolbox that we can have a conversation about. And let's choose what you want and what works best for you.
A word that we use all the time is nuanced. Every woman is so nuanced.
I really hate that word.
We're these beautiful little machines, and they need a little bit of tinkering, and everyone is totally different.
Yes, they're special little unicorns. That's what I tell my patients. I'm like, everyone is a special little unicorn. Everyone. Yeah.
I love that.
It's
I don't
true.
think I've heard you say that.
Yeah.
That's awesome. Be a unicorn.
You
I wanna
are.
Be your unicorn.
You are. You are. All right. So how about transdermal options? How many of you think, the big buzz on social media is the patch. The patch is, has everyone heard of the patch for transdermal? Show of hands, right? Do any of you, and so there are a lot of other options besides the patch, because quite frankly, people don't want to stick that on themselves, or the adhesive is difficult, or they can't tolerate it. So there are other options. One is the patch. There's one big one that can go for a week. There's one that you can choose twice weekly, but then there's also the gel, the spray, and a vaginal ring, not to be confused with a local vaginal ring also. So there are, again, lots of options. Those are all the different transdermal options, or through the skin, not oral, that goes through the liver. So the patch is not the end-all, be-all. And some people really just don't like it, and they don't want to have to change it. So, or their symptoms are such that they need something every single day. They're like, listen, I get hot flashes at night, so I'm going to tailor your hormone therapy. Or if you're perimenopause and you need like a little spray that week before your period, then you can do that, because that's when you're getting your hot flashes. So those, a lot of options, and not just the patch. So if you're seeing a lot of that on social media, make sure that when you're going to your clinician, they talk to you about all the different options so that you can choose the one that's best for you.
Yeah, and I'll just add, when I first started being in this space, I was, I'm old, so I've been prescribing since before the WHI, when I thought there was only Premarin and Provera and Prempro, and So I'm used to prescribing those things. And then when I got back into this space, and everybody wants to fit in, right? So transdermal. But for certain women, they're like, okay, it's bad enough that menopausing is a full-time job. I got to eat the protein. I got to run on the treadmill. I don't know whether I'm sprinting or if I'm sprinting or zone 2ing. And then I got to lift the heavy weights, and don't forget the fiber and then calcium. And then, it's like, now I got a testosterone gel on my leg. I got a patch over here. I got a tablet in my vagina, and I got cream on the outside. And it's like, for the love of God, I'm wet all the time, and it's not for good reason, right?
That's right.
And so take a pill. It's okay. For women aged 50 to 59, the risk of a blood clot, that's what we're concerned about, right, is 5 women out of 1,000. When we add oral estrogen, it increases your risk by 1.5 more women, which is about 0.1%. Do you know what your chances of getting a blood clot when you're pregnant? It's like 20 women out of 1,000, and postpartum, 6 weeks postpartum, up to 6 weeks, it's 65 women out of 1,000. So you've already been challenged, right? If you've been on birth control pills, you've been pregnant, you've been postpartum, you've already been challenged. You didn't get a blood clot. Your bioidentical hormones, it's okay. And that risk is only increased for the first year. And then it goes back down to baseline. Just being you could get a blood clot. So if you're tired of,
aging,
lotioning your whole body and your legs, then stop. Take a pill. It's okay.
Continue to lotion the vulva and vagina. However, please don't stop that.
Don't stop.
Forever. That's what they ask, right? How long do you use vaginal estrogen? Until you die. Forever.
Yes. Bring it with you into your casket or crematorium.
Yes, I will be buried. I will be buried with all of that. Don't take it off of her.
Yeah.
I was in the bathroom the other night and put my patch on, and then came out and got into bed with my husband. And I said, do you know how I think of myself now? Like Iron Man, with that blue thing in the middle of his chest, and if anyone takes it out of him, he'll die. It's like, this is what I am like now. If anyone takes his patch off me, I am dead.
Yes.
Yeah.
This is my lifeline.
All right, so we have time for one more.
Yeah.
Which one you want to do? The threesome question?
Oh, the threesome? All right.
It's okay.
Side effects of hormone therapy? Is that what we're doing? All right, so estrogen for you.
Okay, side effects of estrogen. Jackie Piasta, wonderful nurse practitioner here, says the 4 Bs: bleeding, vaginal bleeding, bloating, bitchiness, and breast tenderness.
Yes, progesterone. So some water retention, some bloating, some increase in reflux, and then fatigue and sleepiness, which is why we give it at night.
Testosterone. Isn't it amazing when you get in the car and you find all your hairs? Everybody should have tweezers in there.
Yeah.
So we want your testosterone
Only
levels.
Only the sun can show.
Right, exactly.
Yeah.
So we want your testosterone to where you were when you were 25, between 55 and 100. So you might get some blemishes. So whatever your blemish history is in your mid-20s is probably your cue that you have enough testosterone. I called Jackie, as a matter of fact, bemoaning the blemish that would not go away. And she's like, aren't you on testosterone? And she's like, yeah. She goes, it's working. I'm like, oh, yeah, it is. I forgot about that. So that's really all you should expect from that, from testosterone.
Yes. All right, so we're going to wrap it up.
Yeah,
we're going to wrap it up now.
And don't forget to follow us, shameless plug. You can follow us as the Dusty Muffins, and all individually as well. We really do love getting our followers up. And we launch new podcasts every week. Great content, fabulous guests. Just a sneak peek, we just interviewed Dr. Kelly Casperson this week, so that'll be launching next. And wait till you see the dish we have going on there.
So thank you all. We appreciate it. Hope you're having a great time.